You did not specify when.
Yeah. Only Colgate too.
Okay.
Yeah.
So, okay, I heard a one-word answer.
Yes.
Gout. So tell me why gout.
Feathery crystals, palisade granuloma.
Feathery crystal, palisade granuloma, and then in this particular case, PEH, where it's being spit out to the surface. So it would be a verrucous lesion of gout. Yes, absolutely gout. So just as with anything else we do, it's just a matter of recognizing the pattern, recognizing, in this case, the substance that's deposited. So.
Like there's some kind of like pinkish purplish deposits, kind of looks like calcium.
Yeah, calcium that looks like it's being spit out through the epidermis. You think this was a macule?
No, I have papule.
Yeah, papular nodule. Are you aware of any subepidermal calcified papule? But subepidermal calcified nodule is the name, right? Which is. So what's the usual demographic for that?
Like children, I think it said either like the heel or the chin.
So it's either where they got their PKU heel stick, where it calcifies and spits out, or the vast majority are like between age 8 and 12. They show up with this thing under their chin, usually.
From trauma or just because?
Probably stuck a pencil up there.
Yeah.
Yeah, I mean, who knows what kids do? Okay, how about this?
Looks like there is some pigment in the superficial dermis. Maybe like oxalosis or ochronosis, like the bananas.
Okay, so is it more like oxalosis or more like ochronosis?
I think ochronosis. Oxalosis is more like little crystals.
Oxalosis is crystals, many of which are intravascular, that look sort of like a four-leaf clover, and these are long ochre-colored banana bodies. So, therefore the term ochronosis. And endogenous ochronosis related to
Alkaptonuria.
correct, and exogenous ochronosis related to hydroquinones, phenol, things of that sort.
Bob Ross has yellow ochre on his palette always. In case you're wondering what color that really is.
I thought it was like an acronym.
Yeah, so did I.
We have had Southern residents who thought that the banana bodies resembled okra, but it is not okra. It's ochre, like the color ochre.
Funny.
Okay.
So it looks like we have pretty thickened epidermis, not epidermis, dermis collagen bundles, some.
Corneum's probably a bit thick too.
And then some deposits in the papillary dermis, kind of.
That's sitting all by itself,
No.
not surrounded
It's
by
definitely with the
melanin.
of- I'm sorry?
sitting all by itself, pink, not surrounded by melanin.
No, it's surrounded by melanin.
It is definitely surrounded by melanin. So tell me about pink chunks surrounded by melanin.
Makes me think of like an amyloidosis.
Of an epidermally derived amyloid. Correct.
Put biopsy. Got some pigment down deep.
Pigment?
Fat.
What does the pigment look like?
It's a little sparkly.
Little refractile, flip down your condenser,
Hemosiderin.
it becomes way refractile, so it looks kind of like hemosiderin. So it could be post-hemorrhage hemosiderosis, could be where you had a nail or other metallic foreign body, or in this case, where you are getting intramuscular injections of iron for iron deficiency.
That's cool. So it probably clinically would have been bluish.
Given how deep it was, probably.
So you have pink fissure material in the dermis. What do you think about nodular amyloid?
So nodular amyloid's usually surrounded by plasma cells, right? This is surrounded by granuloma,
Oh, it's more feathery looking.
and it is definitely
gout.
feather looking, so it is gout, not amyloid.
Yeah, there's some pink amorphous deposits here too.
Pink amorphous deposits in this chapter?
Thinking more kind of amyloidy here.
Yeah, these are more chunky, like amyloid. This one doesn't have a ton of cells around it. Many cases of nodular amyloid are heavily surrounded by plasma cells. The plasma cells tend to be clonal, and there's evidence that what they represent is marginal zone lymphoma that amyloids itself to death.
Looks like we have that ochre color again.
Looks like an ochre color. Yes.
Ochronosis.
So it is ochronosis once again.
What do we think? Why did we do this before? Looks like some mucinosis position. Mucin position.
Looks like mucin deposition. And is it A, mucin deposition pushing apart perfectly normal large collagen bundles, or B, mucin with wispy degeneration of the collagen bundles?
The second wispy.
The second one, wispy degeneration. And that you can see in mucinous nevus, you can see in focal mucinosis, you can see in pretibial myxedema. The difference between pretibial myxedema and scleromyxedema is that in pretibial myxedema you get full thickness, mucinosis, and degeneration of the collagen, whereas in scleroedema. In scleroedema, the collagen is normal, just pushed apart in the deeper portion. In scleromyxedema, what do you normally see?
Fibroblast.
Yeah, too many fibroblasts. So it doesn't really hit your eye as mucin, it hits your eye as a busy dermis with too many fibroblasts.
I really think collagen. I think it might be a kid. A little bit of superficial infiltrate with some pigment, so maybe like macular amyloid.
Yeah, you look to see if some of those chunks up there, if they're just Savant bodies or if it's amyloid. Let's see. So there's your skin. And you have that stuff. So give you the view of the whole background, right?
Yeah, so
So NSF tends to be too many or too few nuclei?
too few.
NSF tends to be too many, or
Too many.
too many nuclei in NSF. NSF looks just like scleromyxedema, except that it's deep heavy instead of top heavy. In this case, you certainly have areas that don't have a lot of fibroblasts, right? But you do have funny collagen that's kind of small and haphazard in all directions and often whorl-like. So what would give you these whorls and nodules of new collagen? Yes, hypertrophic scar. Yes, hypertrophic scar. And then what's sitting in this hypertrophic scar? Kind of amorphous granular stuff.
Steroid.
Say again?
Steroid.
Yeah, triamcinolone. Right, so that's what triamcinolone looks like when it's injected. Notice the distinct absence of granuloma around it because it's triamcinolone, right? So you're not going to get an inflammatory reaction usually.
Probably, or it could be colloid milium or like EPP. It's kind of wrapping, but
Yeah, so in erythropoietic protoporphyria, it would be wrapped around vessels and be high and it bears some resemblance to EPP. Other thoughts were amyloid because it is fissured. Then the biggest lookalike for amyloid is colloid milium, and one of the clues for colloid milium is you see altered elastic fibers becoming the colloid, right? So colloid milium you can see in kids as, inherited genoderm. You see it in adults just as chronic sun damage. So on the ears in people in rural West Texas, it's considered normal. It's just a matter of how much sun you get. This might be a better example here. So first off, where do you think you might be?
On the scrotum.
So lots of smooth muscle, and it's not in big bundles like you would expect around areola.
Right.
It's more like anogenital type skin, and then you have
Like some calcified nodules.
like calcinosis, and there's actually some bone in here. There's osteoid as well. So scrotal calcinosis originates from what?
Like EIC.
Yeah, it's what happens to old EICs on the scrotum.
It looks like deeper in the dermis, the collagen's more spread apart, kind of like scleroderma.
And it's thin, little wispy collagen, just like we saw before. No,
More
it's big
regular.
bundles of collagen that are fenestrated and pushed apart by mucin. So this is
Scleroedema,
scleroedema of
bushy.
Buschke, correct? Which you see post-streptococcal, you see in diabetics, which is the most common. Pebbly, red upper back, thick in a diabetic. You can see it paraprotein associated, and the post-strep ones are pretty dramatic. I have seen people who they blow up and look like the Michelin Tire Man for several months, and then they slowly deflate. And the histology is the same in all the variants. Make sure we're getting everything here represented, or at least a good representation. And then you're down in the sub-Q.
So we have
the
smaller
subcube.
vessels with what looks like bluish deposits.
So every last tiny little capillary-sized vessel.
Calciphylaxis.
So that's what defines calciphylaxis, whereas Monkeberg's medial calcific stenosis is your large arterioles. And that's just, chronic hypertension, chronic atherosclerosis. Whereas this, where it's every last little capillary that's calcified, that's calciphylaxis. And non-uremic calciphylaxis is becoming more and more common. It's now our predominant type in many hospitals. Is not someone who's diabetic and end-stage renal failure, but a non-uremic patient with the dwindles who has rapid weight loss. So anyone gives you a hard time over that extra donut, you are preventing life-threatening calciphylaxis. Let's just make sure. I don't want to do too many repeats because I want, as we go through the year, I want more and more time for potpourri. Because that is reflective of real life where you don't know what chapter things come from. Let's try this. That one may not be fair. Let's get that one.
What was that supposed to be?
Let's try this.
Get a lot of space between collagen down deep.
And in this case, you're seeing lots of blue granular stringy mucin in labs that are dedicated derm path labs. You're going to see it because they tweak the hematoxylin so that you can see mucin. If you're sharing your lab with GI pathologists, they always want to downplay the hematoxylin, and you just see fenestration. You see white space between collagen. So that's just lab dependent, whether or not you see the mucin.
So you have a busy dermis here.
It's definitely a busy dermis. And is it busier at the top or busier at the bottom?
It's busier at the top.
Busier at the top, lots of fibroblasts, and a little bit of a grayish hue. So what are you thinking?
So more scleromyxedema.
Probably scleromyxedema. The nephrogenic systemic fibrosis will look similar, except it starts down in the septa instead of high. And if you get the lollipop bodies, the osteoid around the elastic, that only happens in NSF, does not happen in scleromyx. Both of them have CD34 cells tracking along elastic fibers. That's shared between the two. Pretty pink slide. And what's especially pink?
Is that good collagen or elastic fibers?
The elastic fibers. And what condition do you normally think of where the elastic fibers are super, super pink? Something you normally think of in Morpheus scleroderma.
Okay.
In this case, it's sclerodermoid GVH. But you can see it in sclerodermoid porphyria. Any sclerodermoid condition, you can get that.
Purple deposits. I don't think that's elastic. Maybe oxalosis. Usually a little bit more yellow.
Yeah, oxalosis is bluish or they're clear.
clear.
Clear and refractile. This is definitely bluish, right? Little squiggles.
Is it calcium?
They're certainly calcified, little
Calcified?
squiggly fibers up in the dermis.
PXE?
Yeah, so it's a PXE pattern, but it's actually the periumbilical stria in an older woman who's had lots and lots of kids. Which is
Calcific
the-
elastosis?
Perforating calcific elastosis, correct, which is a lookalike for inherited PXE. Okay. I think we hit most of the big entities. The others you definitely had in your unknowns, so you had a good representation of everything. Let's go to potpourri. Try to hit as much as we can. I'm gonna pick out something from that middle shelf there. That ought to work. That's probably a good enough slide.
Looks like something's going on the basal there. Maybe one of the cytic lesions in the iris.
Maybe melanocytic. There's certainly a flat bottom fibrosis displacing the elastosis. There are poorly nested units lined up at the DE junction. So I think MIS is probably a pretty good bet.
It's weird not doing the dermis. Looks like it's got a lot of. I'm sure for spindly cells. Maybe like an aroma of some sort.
Yeah, fascicles with space between them. So clefts between fascicles of wavy cells. So it looks like a type of neuroma. It's a little round to oval bump on the face.
Traumatic, maybe?
Yeah, traumatic or PEN,
Yeah.
palisade encapsulated neuroma. Should be a very common thing on a face.
Looks like there's some capsulitis and there's some dyskeratosis.
So you going for warty dyskeratoma?
That's kind of what I was thinking.
What do you think about nuclear cytoplasmic ratio in this warty dyskeratoma?
A little high.
Yeah, this would be an evil warty dyskeratoma. So what kind of evil warty dyskeratoma?
A malignant.
And acantholytic squamous cell carcinoma. Yeah. So acantholytic squamous cell carcinoma, you will have single cell dyskeratosis. You will have acantholysis, but you also have atypia. So invasive acantholytic squame. Happy skin? So then the question is, what is making this skin unhappy? Let's try to look down at the skin and see what is making the skin unhappy.
So if you have a bluish hue beside the vessel,
A bluish hue or haze all around that vessel. So what is this? Ecthyma gangrenosum, correct. Which is cutaneous manifestation of Pseudomonas sepsis, correct.
Is there a reason that on the last one though, like they were like Just like yellow and strips of it. Sorry. It's kind of like a yellow brown. Is that just like the dead cornea?
No, that's formalin pigment.
Okay.
You often get, where you have necrosis, you often get bits of formalin pigment. Buffered formalin, buffering is to help prevent the formalin pigment from forming. It's a black stippled pigment that adheres to things. That's maybe not the best. This is probably a better one to do.
It looks like we've got some like serum crust.
It's definitely serum crust.
And then like the rest kind of looks dead.
Is this
the
dead?
The epidermis doesn't, but the papillary dermis is very like pale and spread apart.
Pale and spread apart, like maybe it's not there, it's pushed down, and what is there?
There's
What kind of
ears? Yeah.
EOs? So you got a lot of stringy stuff and edema and EOs where your papillary dermis should be.
I'm not sure.
Any thoughts? You could say.
Like a bug bite or something.
It could be bullous bite, could be pemphigoid, EBA. It's a subepidermal bulla with EOs. So you're seeing all that stringy stuff is serum and fibrin.
Okay, so they're just
and,
missing the bottom part,
correct.
like underneath. Okay.
Yeah. So the bulla may be a clean split, or there may be debris in the bulla. I think it's the debris in the bulla that threw you off. But you had an epidermis lifted off, you had lots of edema and stuff, and then you had EOs.
Underneath was. I thought that was the
Yeah.
underneath.
Got it. Okay, so first off, where do you think you are in terms of location? Pretty big muscle bundles, right? And skin where the collagen's kind of tight. So, would be good for like breast tissue with those big collagen bundles. They're way too big to be anogenital, and the collagen's too dense for it to be anogenital skin, so it's more like breast. And then what's happening on this breast?
Looks like something bad.
Looks like something bad, agree.
Nuclei all look not normal.
Pretty horrible,
Yeah.
right? And those horrible nuclei surround what kind of space?
A little vessel.
Yeah. Where's the wall of the vessel? Or are the nuclei the wall of the vessel?
Yeah, they are.
So what kind of horrible thing do you think is happening on this breast?
It's like they're infiltrating the vessel.
Infiltrating vessel, or, given that this is all blood between these cells, maybe the cells are endothelial cells, ugly, horrible endothelial cells.
It's like an angiosarc or
What would
something
give
like
you a horrible high-grade angiosarc on a breast?
that. They had radiation before.
Stewart-Treves, right? So that's exactly what this is. So this is post-mastectomy and radiation, or post-lumpectomy and radiation, chronic edema in the breast, and you get high-grade angiosarcoma.
Looks like a KA.
Looks like a keratoacanthoma with the glassy epithelium, hypergranulosis, like hair follicles spreading out to these big, broad, eosinophilic things.
Sebaceous.
Why do you say sebaceous so quickly at scan?
It's blue with red ducts.
Blue with red ducts, that's a pretty good bet for sebaceous, right?
So probably adenoma. It doesn't look super
So,
atypical.
Doesn't look atypical. So somewhere in the sebaceous adenoma group, if it's sebaceous adenoma, what might it be associated with?
Muratori.
Muratori. And then what do people with Muratori get?
The last slide we just saw.
Not necessarily angio.
No.
KAs.
Oh, keratoacanthoma. That was the last slide. You are correct. So they get KAs and they get sebaceous carcinomas and they get occasionally and they get sebaceous KAs certainly and they get gut carcinoma. And how do you check for Muratori?
We
You probably
used to do
don't do
microsatellite
microsatellite
instability,
instability anymore, right? Because it makes about as much sense as looking for neurofibromin mutations in a neurofibroma.
So probably family
That's
history.
how you get a neurofibroma, right? So you look at family history. You look, do they have multiple KAs? Do they have multiple sebaceous neoplasms? Do they have family history of any of the associated tumors?
Is the internal malignancy typically more like low grade? Isn't that what you said in the past?
The gut carcinoma is low-grade gut carcinoma. That's correct. Which is just the opposite of things like Cowden's, where it's very high grade.
So you have ulceration here, crust.
Did you say ulcer?
Yeah, maybe
Base of
not.
an ulcer, you've got no epithelium,
Okay.
right? Here you got maybe too much epithelium.
Yeah, maybe some kind of falling apart like a candle.
So it's definitely falling apart. In what layer is it falling apart?
Say more of the granular.
Granular layer shot full of holes, and the granules, which are normally blue, in this case are chunky, weird, and both red and blue.
Okay.
So epidermolytic hyperkeratosis, and is this a lot of skin, or is this a little cup-shaped lesion, kind of like a keratoacanthoma?
Cup-shaped lesion.
So what would you call an epidermolytic acanthoma? Yep, and where do most occur? 90+% are scrotum and vulva, genital. So the patient thinks they've picked up some kind of venereal wart. You try to explain to them after the biopsy what an epidermal acanthoma is. They don't care. You told them it was not the venereal wart. They can go home and tell everyone it was not, and they're just fine with that at that point.
A little papule here. All angiofibroma.
Yeah, a little angiofibroma, if it's concentric around vessels, or what kind of thing has pyramidal, stellate, plump epithelioid cells forming a little collagenous papule with overlying acanthosis? So kind of variant of DF with stellate epithelioid cells. Anybody? Epithelioid histiocytoma.
Okay.
And mutation that you can look for in epithelioid histiocytoma. They're ALK1 mutated. So it's ALK1 mutation is pretty reliably present in epithelioid histiocytoma.
Punch biopsy. Mounds of parakeratosis.
Mounds of parakeratosis. Tell me about the epidermis.
Some spongiosis.
Kind of spongy. So it looks like a subacute spongiotic dermatitis. And this particular subacute spongiotic dermatitis has a little bit of red cell extravasation in it.
PR.
Yeah, so maybe PR. I mean, it could just be subacute dermatitis, right? It could be nummular. It could be all kinds of things. But the presence of the red cell extravasation it favors PR if the history fits.
Looks like leiomyoma.
Leiomyoma? What kind of leiomyoma shells out like a marble like that with vascular spaces inside?
Angioleiomyoma.
Angioleiomyoma.
Alright, so there's a little basaloid.
Kind of pink strands, blue buds.
Yeah. Infundibular cystic.
Like infundibular cystic BCC, but the patient is covered with these little bumps, as is his dad, as is his brother, and they don't turn into anything.
Basaloid follicular hematoma.
Basaloid follicular hamartoma, which looks a lot like infundibular cystic BCC histologically.
Looks like maybe this is histiocytes. Granulomas. That's maybe stellate.
So stellate or palisaded granulomas, and then what's in the granuloma?
That looks like some neutrophils.
Some neutrophils, what else? Kind of some space.
Yeah, some space in there.
And what do you think washed out of that space?
Some mucin.
Oh, some mucin.
GA, I think.
Yeah, GA, palisaded neutrophilic granulomatous dermatitis, PNGD. So it depends on the history. You know, PNGD looks a lot like GA in people with arthritic syndromes. So a lot of people just consider it in the GA spectrum, which is fine.
Pinwheel or spoke wheel.
Kind of like pinwheel little spokes coming out of smooth muscle. So this is probably piloleiomyoma, and this person has multiple of these and sort of a dermatomal blastoid array, which probably is blastoid, not dermatome, right? And so what would you worry about?
Well, with multiple leiomyomas, it's Reed syndrome.
Reed syndrome, and what else might have they?
Kidney
Kidney what?
cancer.
What kind? Oncocytoma?
No, this
That's Birdhog-Dubé. So this is
it's not chromophobia.
renal papillary.
Okay.
That's the usual one that they would get.
Is that a particularly bad one?
Yeah, renal papillary is not nice. Whereas the oncocytomas are lower grade, papillary is not low grade.
Got parakeratosis.
Parakeratosis, anything present
Acanthosis.
with the parakeratosis?
Yes. Newt?
Yeah, newts, para,
So it's kind of
then
like
not so much
sandwich
newts,
and-
and then lots of newts and para again, kind of sandwichy. So this is psoriasis. Very good.
Looks like the fat is pretty high.
Fat high in the dermis.
Is like a nevus lipomatosis.
Yeah, so number one, it could be just a fatty skin tag, right? Or if this is a blastoid array of lesions sort of down on your butt or thigh, then that's nevus lipomatosis. What if these were bumps occurring in a little girl who was born with red stria and microphthalmia and missing some fingers and teeth?
Golds.
Then that goes with later lesions of Gold syndrome. Can all look somewhat similar histologically.
Maybe the Paisley tie differential.
A Paisley tie differential. And so, what do you think about Paisley tie differential? What do you want to know about the patient?
The location.
Okay, so this was on the upper lip, plaque-like lesion, 52-year-old male.
Probably a MAC.
Probably microcystic adnexal carcinoma, but I lied. This is lots of tiny little bumps on the eyelids of a kid with Downs. So that's like syringoma, but I lied. This is a 78-year-old person with a progressive scar-like lesion on his forehead.
More like morphiform BCC.
Or like morphiform BCC, but that whole thing was a lie. This is a young woman with a very stable donut-like pale lesion on her cheek,
Like a desmoplastic trichoep.
like a desmoplastic trichoap. So what have you learned?
You're a liar.
I'm a liar. Yeah, that's the key thing. And then clinical pathologic correlation.
Also for desmoplastic trichoeps, what's the management for those? I mean, you go ahead and excise them because of the possibility of...
It depends on the patient and history of growth. So we have a faculty member of a department at MUSC who has one and has decided not to get it off because thinks it was there and stable for quite some time, and that decision was made almost 4 years ago, and it's sitting there just like it was sitting there, and nothing's happening to it, and that's not a bad decision. You've got someone where it's, they're out of the usual age demographic, and or there's question of growth and behavior. You got to individualize for the patient. But, if it's a DTE, that is a completely benign lesion. The problem is, how certain are you that it's a DTE versus something else in the Paisley tie differential? 30-year-old woman, stable donut-like plaque on the cheek, you're pretty confident, right?
So it came back after it was biopsied?
No, only a portion of it was biopsied, not the whole thing. Right? So, looked at it, said, it looks like a DTE, right? Patient was concerned, wanted a biopsy, came back, Paisley tie-like, right? Put that together with your clinical presentation. That's almost certainly what it is. What do you want to do? It's not too big. We could take it out. It's right in the middle of your cheek. The cheek's a little podorange sebaceous. It's definitely going to leave a scar. You can hardly see what you have now. So
Some acanthosis. So you're thinking Spitz, DF, or granular cell.
So acanthosis overlying a tumor would be Spitz, DF, or granular cell as the big three. Which of those has ringed siderophage?
DF.
Dermatofibroma. Done at scan. Well done. Where's that easy button?
That was easy.
So slide a little bit faded.
So you guys compare keratosis.
You have parakeratosis, and is it just parakeratosis?
Second use neutrophils in there.
Neutrophils in there, and red cell extravasation, and interface dermatitis with necrotic keratinocytes. So what would give you a dirty scale crust with interface dermatitis and red cell extravasation?
PLC?
Yeah, like pityriasis lichenoides. Well done. What's that?
It's amyloid histiocytoma.
Maybe an epithelioid histiocytoma. Is there any, or maybe a fibrous papule, which can also have stellate cells? Anything you could do as a marker to tell you which one it is?
ALK1 mutation.
Maybe ALK1 mutation, which would go more
That
with
was
the
easy.
epithelioid histiocytoma. Interestingly,
once.
that's an identical slide, right? The prior one was labeled epithelioid histiocytoma. This one was labeled angiofibroma. By someone who already did it. And, this was two different fellows handling recuts and labeling them. And the truth is, that's the differential. And if you did an ALK1, you'd know, right? They both tend to have stellate cells. The 13A is maybe a little more characteristic of the. Well, actually, both could be 13A positive, but alkalin's probably your best test. Okay, so what do you think about that little basaloid bud?
Basal cell.
Basal cell. You gonna stick with that?
Is that tumor follicular?
So TFI, but TFI is usually pink, not blue, right? Underneath, you've got, so why is it sitting on top of that fibrous thing? And then there's also plate-like acanthosis there.
DFS.
Because it's follicular induction on top of a dermatofibroma.
Cyst-like structure.
Yes, cyst-like structure, no epithelial wall.
Yeah, maybe metaplastic synovial.
Yeah, metaplastic synovial cyst, and if from the dorsum hand, then that type of metaplastic synovial cyst is a ganglion. Well done. Someone needs that easy button.
That was easy.
There we go.
All right. There's a bluish tumor, a little crusty. I don't see any ducts in it. I'm worried about basal cell. It's palisading pretty well.
Yeah, and it was labeled basal cell. What do you think about that? What do you think about retraction? What do you think about all of these plump collections here in the
That
concentric fibroblasts like stroma?
A little bit less basal cell. It might be more trichoep.
Might be more trichoep. So, I mean, I'd look really carefully at the history, the age demographic. Is this a solitary lesion? Are there multiple lesions? Any history of cylindromas?
Focal area of inflammatory cell.
Very focal area, right?
Yeah.
Very, very focal. Kind of sitting there, ball and claw, and one set of papillae, a little perikeratosis, like nitidus. Very good.
Tad versus Grover's.
Tad versus Grover's
Haley.
versus Haley. Anything that's going to help you with that?
Rings. See red rings.
Red rings. See anything other than red rings?
Maybe blue.
I'm not sure. I'm picking out blue. I'm seeing only red.
It's
Red.
acanthotic, so it's
Yeah, it's very acanthotic, and that also favors Haley over the other possibilities. So red rings only favors Haley. The degree of acanthosis favors Haley as well. Who described it first?
Haley.
Yeah, Haley. They were either brothers or father and son. I don't know which one. They described it simultaneously, obviously.
You were good guys, right?
Haley and Haley did nothing bad that I know of.
Got a pretty cellular dermis, and then there's pigment up at in the papillary dermis. Looks like a nevus.
Probably a nevus. Hey.
Like this lecture.
So there was some acanthosis right here.
Yep.
This little area, inflammation. Is it kind of like
What are all of those gray vacuolated cells? Yes. What are they?
coilocytes?
Coilocytes. And so this is probably what?
Like a wart?
Yeah. Is this a very papillomatous wart, or is this a fairly flat lesion.
Flat, that's how I feel.
So that's verruca plana.
Looks like
Pretty hypercellular.
Pretty hypercellular with these bland little ordinary looking nuclei. With no atypical mitoses whatsoever.
I mean, I'm trying to figure out what the cell origin is for.
So if you've got these atypical spindle cells slammed up against the epidermis, what could the cell origin be?
It could be spindled squame, leiomyosarc, atypical fibroxanthoma, or spindled melanoma.
Any stains you want?
Yeah, I mean, for squame, I guess pan-keratin.
So a keratin would be fine, a high molecular weight keratin would be fine. P63 is actually a really nice one because it's a nuclear stain. Any of those would be fine for squame.
For leiomyosarc, I'm not sure if it's like CEA or.
No, CEA is not so much leiomyosarc.
I'm not
More
really
like
sure
Desmond.
Desmond.
Because actin stains are too sensitive. They pick up AFXs and squames and all sorts of things. Whereas Desmond is a little more specific.
And then AFX is like a exclusion. Yeah.
Diagnosis of exclusion, but CD10 is commonly positive, like most of God's children, except for most of the other things in this particular differential diagnosis, right? And then for melanoma,
I guess you could do a bunch of different ones.
these are spindled. So which ones don't work reliably when they're spindled?
To be honest, I'm not sure.
A lot of them. So which ones are left that work reliably and spindled?
Sox
S100 or SOX10?
Gotcha.
This looks maybe like it's like bulbous down into the deep
Yeah,
dermis, like
bulbous
a DPN.
down into the
actually.
dermis, like a deep penetrating nevus or a blue nevus.
There might be a little different cell proliferation at the periphery there, so it could be combined.
Could be a combined nevus.
I would see if it different. I mean, melanoma obviously as well. I'd see if it diffracts.
What kind of melanoma? What kind of melanoma is kind of blue and dendritic?
Eccrine. Or the equine. Right?
Equine.
Yeah.
So like the ones that horses get, which are never equine because horses only have apocrine glands, right? So-called equine, which is blue nevus-like melanoma or uveal melanoma of skin, could be in your differential, as could a blue nevus. So any things you can do to help differentiate.
Let's see if it diffracts. If it blacks out.
So
it's
you
good.
look to see if there's diffractive collagen in it. If it's all brightly diffractive collagen, that's a good thing, right?
You want it to black out.
That would be a bad thing, right? So the brightly diffractive collagen is what you get in the dendritic melanomas, whereas all the blue nevi, except for epithelioid blue, have their own sclerotic stroma that's not refractile because it's newly synthesized ropey collagen. Any other stain that you could get? What kind of mutation is typical in uveal melanoma of skin?
GNAC.
Say again?
Is it GNAC?
GNAC, but what's easier to test for? What happens in top of the GNAC? They're two-hit lesions. So I heard BAP. Yeah. So they tend to be BAP mutated. What if it's if you're thinking epithelioid blue nevus, what's usually mutated there?
Carney complex.
Yeah, which is what?
Parker,
which you can actually look for now because most labs, if it's a university lab or a larger lab, they're going to do next-gen sequencing and they can tell you if there's Parker. And then it could be sporadic epithelioid blue, or could be epithelioid blue associated with what syndrome?
Carney.
You said it Carney's, and what do people with Carney's get?
Lentiginous atrial myxomas, blue nevi.
Yep. Okay. So one last one, because we're at the end of the hour.
So I have blue cells in there, some necrosis. It looks like they look bad on the skin.
So kind of centered around a vessel. And then you have lots of smaller vessels proliferating. And you have lots of lymphs and lots of EOs. Do you know any kind of angiolymph with EOs?
Angiolymph like hyperplasia.
Yeah, ALHE. Okay, I think we're done for today.
Lost mine. I mean, I think it's